Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Imagine executing a great vascular procedure. You cross the lesion, the stent is placed, blood flow is completely restored, and the post-intervention imaging looks good.
Right.
You expect the patient to wake up relieved. Yet, 6 months later, that same patient is sitting in your clinic, still experiencing the exact same level of pain.
It is frustrating.
It really is. Today on the Deep Dive, we're exploring why that disconnect happens so frequently when treating venous origin chronic pelvic pain in women.
Yeah.
Our sources for this peer-level discussion are the newly published 2025-2026 Practice Guidance Document and Consensus Statements from the Society of Interventional Radiology.
And our mission today is to extract the practical changes required for the endovascular suite. We will focus on patient selection, precise hemodynamic thresholds, device deployment specifics, and how to navigate the conflicting data around treating combined venous reflux and obstruction.
We should probably start with how the guidelines demand a shift in our nomenclature. I mean, the authors urge the field to abandon historical terms like pelvic congestion syndrome, May-Thurner syndrome, and nutcracker syndrome.
Right.
And those terms are embedded in our clinical documentation and billing codes.
They are, but those historical labels are anatomically imprecise. They fail to describe the underlying hemodynamics.
Well, that makes sense.
So the guidelines recommend using the Symptoms-Varices-Pathophysiology classification. It parallels the clinical etiology anatomy pathophysiology classification used for lower extremity venous disease.
Oh, I see.
Yeah, the new framework forces the operator to classify the clinical presentation, the exact location, and the distinct hemodynamics. It differentiates between primary reflux, secondary reflux, and obstruction.
Identifying the right patient population is the foundation here, considering venous origin chronic pelvic pain affects up to 1/3 of women presenting with chronic pelvic pain.
It is a large patient population.
It is. But the comorbidity profile is the real challenge. These patients often present with overlapping pain generators, most notably pelvic floor tension myalgia and central nervous system sensitization.
Exactly.
So if we look at the physiology, how does a dilated vein lead to a generalized pelvic floor muscle spasm?
Well, it comes down to visceral somatic crosstalk in the spinal cord. Chronic visceral pain from venous distension sends continuous afferent signals to the dorsal horn of the spinal cord.
Okay.
Over time, that constant bombardment lowers the activation threshold for adjacent somatic nerves.
So the nervous system just becomes sensitized.
Right. The nervous system becomes sensitized, meaning the patient develops referred myofascial inflammation and trigger point formation in the pelvic floor musculature. The physical anatomy of the vein is just the starting point of a complex neurological cascade.
You know, treating the primary venous hypertension is sort of like fixing a leaky pipe behind a wall.
That is a good way to look at it.
If the water damage has already caused the surrounding drywall to rot, and the rotting drywall is the central nervous system sensitization and the myofascial pain, well, fixing the pipe does not instantly repair the wall.
No, it does not.
You still have structural damage that requires attention. This leads to a necessary question about our current practice patterns. When an interventionalist is in the suite, are they treating the true source of the patient's pain, or simply treating a prevalent anatomical variant?
Answering that requires a multidisciplinary approach. Intervening on the venous anatomy without concurrent treatment from pelvic floor physical therapists and chronic pain specialists often results in clinical failure.
That makes total sense.
Yeah, the operator must address the primary venous hypertension while simultaneously managing the secondary pain generators.
To differentiate pathological anatomy from an incidental finding, we really have to look closely at the imaging thresholds. The initial transabdominal or transvaginal duplex ultrasound diagnostic markers are straightforward. An ovarian vein diameter greater than 8 millimeters and perirenal veins greater than 5 millimeters, coupled with real-time evidence of venous reflux.
But cross-sectional imaging is where the diagnostic pathway becomes treacherous, particularly concerning left renal vein compression.
Right. This is a huge pitfall.
Yeah. When defining significant stenosis as a cross-sectional area decrease of 60%, 55% of patients demonstrate significant left renal vein stenosis in the supine position.
55%. But that number does not remain static.
No, it does not.
It drops to just 10% when the patient is placed in the left lateral decubitus position.
Right.
And then it actually rises to 67.5% when the patient is standing. The mechanism here is entirely postural.
Exactly. When supine, the abdominal viscera compress the left renal vein between the superior mesenteric artery and the aorta.
And rolling the patient onto their left side causes the viscera to fall away.
Yes, which physically opens the aortomesenteric angle and relieves the compression. Standing up allows gravity to pull the viscera downward, which narrows the angle and increases the compression again.
So relying on standard supine computed tomography or magnetic resonance imaging introduces severe selection bias.
Absolutely. If an operator plans a major intervention based solely on a supine scan, they are likely to diagnose left renal vein compression in over half of their patients.
Right.
And many of whom simply have physiological compression induced by their position in the scanner.
If the stenosis changes that drastically based on posture, the standard diagnostic algorithms relying on static imaging seem fundamentally flawed for procedural planning. Operators risk overtreating apparent physiological compression.
They do. The definitive diagnosis must happen dynamically. The guidelines suggest real-time hemodynamic criteria in the interventional suite before deploying any devices.
So let us get into the suite. Venous access is typically obtained via the jugular, femoral, or upper extremity veins.
Yeah, and the choice of access often depends on whether the operator plans to utilize specific balloon occlusion catheters or intravascular ultrasound. But the critical intraprocedural step is the pressure measurement.
Right.
Intravascular pressure measurements are mandatory if left renal vein compression is suspected.
The physician should only proceed with ovarian vein embolization if balloon occlusion of the ovarian vein does not elevate the left renal vein to inferior vena cava, a pressure gradient above 3 millimeters of mercury.
Exactly.
Let us dig into the physiology of that 3 millimeters of mercury threshold. Why is that number the cutoff between proceeding and abandoning the embolization?
Well, in the setting of left renal vein compression, the left ovarian vein frequently acts as a compensatory collateral pathway. Blood flows retrograde down the ovarian vein into the pelvic venous reservoir to escape the high pressure in the kidney. When you advance a balloon into that refluxing ovarian vein and inflate it, you are temporarily closing off that escape route.
Which acts like a pop-off valve.
Right. If the pressure in the left renal hilum spikes, compared to the inferior vena cava, you have demonstrated that the ovarian vein is functioning as a necessary pop-off valve.
And occluding that pop-off valve permanently when the gradient exceeds 3 millimeters of mercury traps the renal outflow.
It does.
While the intervention might cure the pelvic pain by stopping the venous distension, the resulting renal engorgement can cause left flank pain, hematuria, and potentially left renal vein thrombosis.
Yes, which is a terrible outcome. But assuming the gradient remains flat and the operator is clear to embolize, the technical execution has specific requirements. The guidelines recommend treating the pelvic venous reservoir first.
Okay, and the standard technique involves using a sclerosant, typically STS or polidocanol, mixed with contrast media for continuous fluoroscopic visualization.
Right. The operator injects this sclerosant as a liquid or foam through the balloon occlusion catheter directly into the pelvic venous reservoir. And this may be done with or without an occlusion balloon.
What is the sclerosant actually doing on a cellular level that requires that duration of occlusion?
STS is a detergent. It requires time to thoroughly strip the lipid bilayer for the endothelial cells of the vein wall. That initiates the inflammatory cascade that leads to fibrosis and closure. Additionally, maintaining balloon occlusion prevents the sclerosant from washing out of the target reservoir and into the systemic circulation. That mitigates the risk of non-target embolization.
Following successful sclerosis, the protocol dictates mechanical coil embolization in the gonadal vein itself. The guidelines instruct operators to oversize their coils by approximately 20% relative to the target vessel diameter. But how does that 20% recommendation hold up in cases with severely dilated veins? Specifically, ovarian veins exceeding 12 millimeters in diameter, where the migration risk is increased.
Oversizing by 20% remains necessary in those severely dilated vessels, but it is rarely sufficient as a standalone strategy. Also, please reference the instructions for use on these coils, as some are sized to the true lumen diameter.
Right.
Veins lack the muscular spasm response of arteries, making core migration a threat. operators utilize vascular plugs as mechanical backstop prior to deploying the coil pack.
Oh, that makes sense.
Yeah. Alternatively, they employ tighter, intermittent coil packing techniques rather than a single loose coil mass. The risk of non-target embolization into the pulmonary circulation really necessitates these redundant anchoring techniques. Some manufacturers require anchoring while some do not. Please reference the instructions for use.
Shifting to the iliac system, the guidelines for stenting non-thrombotic left common iliac vein lesions recommend using stents longer than 120 millimeters. Using a 120 millimeter device for a focal compression seems excessive. Why is such a long stent required?
It addresses the mechanics of stent migration in an undamaged vessel intima.
Okay.
In a patient with post-thrombotic syndrome, the vessel wall contains fibrotic scarred tissue that grips the stent struts. In non-thrombotic compression, the vessel wall is compliant and lacks that anchor.
Oh, because it is just physiological compression.
Exactly. The overlying right common iliac artery exerts a constant downward force on the stent. If an operator places a short 40 or 60 millimeter stent, that force can compress the device and squeeze it out of position. It is often referred to as the watermelon seat effect.
The watermelon seat effect, that paints a picture.
Yeah, the 120 millimeter length provides adequate landing zones in the inferior vena cava and the external iliac vein. That secures wall apposition in healthy segments to anchor the implant against that mechanical stress.
Once the procedural technique for both interventions is established, the more pressing clinical dilemma is treatment sequencing. When a patient presents with both primary reflux and secondary reflux stemming from obstruction, determining which lesion is the primary driver of chronic pelvic pain is the controversy.
It absolutely is. The guidelines acknowledge an absence of high-quality comparative effectiveness trials for combined disease.
We are evaluating conflicting retrospective data here.
Yeah. The document cites one study demonstrating 76% complete symptom resolution with iliac vein stenting alone, even when the pelvic venous reservoir persisted post-intervention.
Wow, 76%.
Right. Based on that data, the authors of that paper advocate for primary iliac vein stenting. They reserve ovarian vein embolization as a staged procedure only if symptoms fail to resolve.
But then the document presents a separate retrospective study demonstrating only a 16.6% symptom relief rate with stenting alone. The majority of the patients in that second cohort required subsequent ovarian vein embolization to achieve clinical improvement. A 76% success rate versus a 16.6% success rate for the same primary intervention suggests we are looking at heterogeneous selection rather than a standardized treatment effect.
Retrospective data inherently captures selection bias. The cohort that achieves 76% success likely consisted of patients whose primary symptom driver was the compressive obstruction, selected by an operator biased towards stenting.
Right.
And the cohort with a 16.6% success rate likely consisted of patients whose primary driver was the reflux.
To provide quantitative guardrails, the document details strict intravascular ultrasound thresholds required to justify stenting a non-thrombotic left common iliac vein lesion.
Yes. Those thresholds require the operator to prove a greater than 50% cross-sectional area reduction or greater than 61% diameter stenosis.
And the guidelines explicitly recommend against intervening below those parameters.
Right. These metrics are adopted from lower extremity advanced venous disease criteria. They provide a quantitative baseline, so operators are not deploying stents based on minor vessel wall flattening observed on standard angiography.
Given that asymptomatic, non-thrombotic left common iliac vein compression is present in up to 70% of the general population, relying solely on anatomical criteria risks significant overtreatment.
It definitely does. A patient can meet that 50% area reduction threshold on intravascular ultrasound and be asymptomatic.
Yeah.
The presence of the anatomical compression does not confirm it is the pathophysiological source of the pelvic pain. Stenting must be reserved for patients where the symptoms are directly attributed to the stenosis after entirely ruling out other etiologies.
Stents are permanent metallic implants frequently placed in young patients. The potential for overtreatment demands a careful evaluation of the clinical outcomes and the known complications. Although not very common, a possible procedural complication is post-embolization syndrome, characterized by a low-grade fever, pelvic pain, or back pain.
Yeah, and that occurs in approximately 20% of patients.
Going back to our earlier analogy, the operator has sealed the leaky pipe, but the localized inflammatory response to the sclerostin and the thrombosis of the large venous reservoir acts like a temporary fire in the drywall.
That is exactly what it is. It is a systemic inflammatory response. Patients must be counseled on this expectation beforehand.
Otherwise, they frequently present to the emergency department days after the procedure concerned about an abscess or severe infection.
Right. It is typically self-limiting and managed with non-steroidal anti-inflammatory drugs.
Another significant topic for patient counseling, particularly during multidisciplinary heart team discussions or when consulting with gynecology, is fertility.
Oh, for sure.
Many of these patients are of childbearing age, raising concerns about packing the pelvic venous reservoir with metallic coils and chemical sclerosants.
Well, the available data provides reassurance there. Embolization of the ovarian vein and pelvic reservoir does not negatively impact reproductive outcomes.
Oh, really?
Yeah, actually, certain small studies suggest it may improve fertility in patients where the baseline venous hypertension was theoretically altering ovarian reserve or causing dyspareunia. The literature contains multiple reports of successful pregnancies carried to term post-embolization without instances of coil displacement or migration.
Providing an honest critique of the source material requires acknowledging the limitations of the evidence base. These guidelines function more as a consensus of expert habits rather than a rigorously tested clinical pathway.
I agree completely.
The reliance on small retrospective case series rather than randomized controlled trials means the data falls short of supporting definitive treatment sequencing.
Exactly.
But it leaves you wondering, as our endovascular tools become more advanced, are we risking becoming so on fixing the mechanical plumbing that we forget to treat the neurological signaling of the whole patient?
That is a critical point to consider.
If you adopt this framework, one specific change you might make in your practice tomorrow is requiring dynamic intravascular ultrasound in a left renal vein to inferior vena cava gradient measurement before embolizing any refluxing ovarian vein. To definitively sequence stenting versus embolization in combined disease, we need a large, randomized, comparative effectiveness trial evaluating symptom resolution and reintervention rates over a 5-year period.
Now here is expert commentary from Dr. Gloria Salazar from UNC School of Medicine.
I really enjoy listening to the podcast on pelvic venous disease by Wisdom. I thought it gave a great framework for physicians that are either treating or looking to treat those patients that are out there with pelvic pain and venous origin chronic pelvic pain. I completely agree that there are a lot of gaps in the research that we need to address, but this episode provides a good way of looking at the patient as a whole, looking into pain generators, looking into how overlapping vascular lesions such as stenosis and reflux can be evaluated properly and treated properly for the patient, as well as provides insights on the techniques that are available and that are most effective in treating those patients. So I would strongly encourage anybody treating pelvic venous disease to listen to the podcast and open their minds about what can be done for those patients.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.